If we'll go into the first slide of the presentation, so we're focusing on the EMTALA, which is the Emergency Medical Treatment. So what we're going to do, the Emergency Medical Treatment and Active Labor Act. Sorry about that. It's a little long to remember. So if we go to the first slide, the EMTALA was brought into action by Congress just in 1986. It was as part of the Consolidated Omnibus Budget Reconciliation Act of 1985. And I kind of like this phrase. I found this in my research, and EMTALA became the de facto national healthcare policy for the uninsured. And the reason being is we'll go into this a little more in depth and further into the presentation. But EMTALA is really the safety net for those who may be under Medicaid or Medicare, or who are uninsured but are found into a medical emergency and need care. Before EMTALA was enacted, patients who had that insurance, had Medicaid or Medicare, or were uninsured, were turned away. Actually, they were turned away services, and so that's what brought about the EMTALA. Now, when the Congress really prioritized its enforcement, they brought in about $1.17 million in penalties from different organizations and medical facilities, which is a big number. And even in 2005, the CMS, they met in order to kind of see what EMTALA was doing and also see what kind of adjustments they could make. And we'll move on to the next slide. This was another quote that I found. It was from Larry S. Gage, and he says, EMTALA also grew out of the congressional concerns about the impact of the 1983 Medicare Prospective Payment System. And basically what this was going to be was that hospitals would be they would be reimbursed for the services that they were giving to specific patients under the Medicare and Medicaid insurances that were under specific diagnoses. And there was a lot of fear that Congress and the government had in regards to what they were going to give in reimbursements for what was filed, but they were scared that there were going to be false filings and they would be paying out more than what was actually being given to the patients. And that's obviously something to be concerned about. They don't want to be paying somebody for services that weren't rendered. And we'll move on to the next slide now. The focuses of EMTALA. It was referred to as the Anti-Dumping Act or law in order to help hospitals or medical centers from transferring uninsured or Medicare or Medicaid patients into not-for-profit organizations, because obviously those hospitals and organizations for profit wanted to make as much money, and Medicaid and Medicare insurance doesn't give a very large payout to those organizations for services rendered. And so they had a very bad habit before EMTALA of dumping patients onto not-for-profit organizations before doing any kind of medical screening or any kind of exam, and therefore these patients were being moved or being told to leave because they didn't have any way of really paying for it. And sometimes grave circumstances fell upon these poor people who were denied services afterwards. And we'll move on to the next slide now. So hospitals and medical organizations have three major responsibilities under the EMTALA, and that is that patients, any patient requesting a medical examination must be given it in order to determine if an emergency medical condition exists. And the examination and or treatment cannot be delayed in order to determine if they can pay for the services or whether they're insured under particular insurances. And so they also need to post signs, which we actually have an example of in a later slide, that very clearly states a patient's right to treatment and examination, no matter what their coverage or ability to pay may be. And then if an emergency medical condition is present, the patient must be treated until the condition is basically stabilized or fixed. That way they can at least transfer the patient to another facility safely without harming the patient or risking further issues for the patients that are being transferred. And also specialty hospitals and specialty clinics, they have to accept transfers from facilities that cannot treat patients for specific things. And I find that a very interesting thing. I work for a specialty clinic now. I work for a spine and neck care facility. And so if we are receiving any kind of referral from a different organization or facility, we are by law under EMTALA, we are required to accept those patients. And I find that very interesting. We'll move on to the next slide now. And the very last thing that I really want to point out about this is that a hospital must report any violation of EMTALA to the CMS or state survey agency in order to make sure that things are being taken care of. If there's a violation, somebody needs to be held responsible, and the person who is put at risk of further damage or further medical emergencies, they also need to be aware that they can be reimbursed or at least helped out in that aspect. So it's the right of every organization to report against their own agency or even another hospital's violation. And we'll move on to the next slide now. And this is just an example that I said that these signs can be found in medical facilities, and these just very clearly explain what a patient's rights are in regards to receiving treatment or examination if they arrive at a hospital or another medical clinic. And so it very clearly states that an appropriate medical screening is available to them, stabilizing treatment. And I think it's really interesting that at least in this sign, they specifically talk about unborn children. So women who go into labor, they are required by law that if they make it into the emergency services, that the facility is to help in the delivery of that child. So give me one moment. My computer decided to go to sleep. All right. Okay, Daniel.
Yep. All right. So my name is Daniel Lay, also of Group 10. I'll be talking about the policies and the enforcement of EMTALA. What the entities that police EMTALA rules and enforce any violations is the U.S. Department of Health and Human Services, and it's through the Office of the Inspector General. EMTALA laws are investigated and enforced through these two agencies, and basically OIG, the Office of the Inspector General, they investigate any firm that engages in any illegal activities to people who fall under the umbrella of the CMS. Next slide. Basically, both CMS and the Office of the Inspector General have administrative enforcement powers with regard to EMTALA violations. There is a 2-year statute of limitations for civil enforcement of any violation. Such penalties for these violations could include the termination of the hospital or physician's Medicare provider agreement. And I found this one interesting in the reading because basically in the reading that I found is that EMTALA laws aren't necessarily absolute law. A hospital doesn't necessarily have to take somebody in. However, if they choose not to, they lose all of their CMS payments, which effectively would cause the hospital to go bankrupt immediately without that funding. Hospital fines for violations can be up to $50,000 per violation. A physician, if he's found in violation of EMTALA laws, can also receive a $50,000 fine. The hospital may be sued for personal injury in civil court under a private cause of action. A receiving facility having suffered financial loss as a result of another hospital's violation of EMTALA can bring suit to recover damages. And the hospital that I work in, because we are a for-profit hospital and we're located maybe 200 yards away from a not-for-profit hospital. They have tried to bring these suits against us before on the grounds that we've transferred patients because they have a higher acute care than we do. And so they've tried to bring these cases against us, but in most cases, we've been able to prove that there was no violations in the moving of patients. But an adverse patient outcome, an inadequate screening examination, or malpractice action do not necessarily indicate an EMTALA violation. However, a violation can be cited even without an adverse outcome. There is no violation if a patient refuses examination and/or treatment unless there is evidence of coercion. Next slide. EMTALA, or HHS and the OIG is the largest Inspector General's office in the federal government, with approximately 1,600 dedicated to combating fraud, waste, and abuse, and to improving the efficiency of the HHS programs. A majority of OIG's resources goes toward the oversight of Medicare and Medicaid, programs that represent a significant part of the federal government and that affect this country's most vulnerable citizens. Next. What is considered an emergency? An emergency medical condition is defined as a condition manifesting itself by acute symptoms of sufficient severity, including severe pain, such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health or the health of an unborn child in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of bodily organs. Now, this is an interesting one as far as the unborn child. For the hospital that I work in, because we no longer have a neonatal care unit for the delivery of babies. So whenever we have pregnant mothers come in, we basically try and stabilize them as quickly as possible and get them over to the hospital right next to us that is set up to handle those sort of emergencies. And the other day when I spoke to a director of the hospital that I work in here in Las Vegas, she told me that they strive to obey EMTALA laws without exception. And she said, even in times when the hospital has been locked down because of potential outside threats, they still have staff members outside the ER to ensure that they're not keeping anybody out that needs immediate medical attention. Next. Why was it necessary to promulgate this legislation? For obvious reasons. Prior to the passage of EMTALA in 1986, hospitals had only a moral obligation to stabilize patients who couldn't verify the ability to pay for care in their facility. Unfortunately, a moral obligation has often not been enough, as explained by Emily Friedman of Hospitals and Healthcare Networks, when she said, prior to the implementation of the Emergency Medical Treatment and Active Labor Act of 1986, a patient coming into a hospital emergency department often had no right to treatment or even evaluation, no matter how dire his or her condition. If patients could not prove that they had the resources to pay for care, they could be turned away or sent elsewhere, sometimes in a taxi, sometimes in foot. They often suffered adverse health consequences as a result of delayed care, and sometimes they died. This was an unfortunate part of the reading as I read through to hear about all the poor people that suffered longer than they ever needed to, or ended up having long-term health problems because of delayed care, or in a lot of cases, people just dying. So the legislation was obviously in my mind, a pretty easy thing to pass on the grounds of compassion and love. Next. Finally, when asked how he felt about the callous treatment for human life, Ron Anderson, who is an MD and a president and CEO of Parkland Memorial Health and Hospital System in Dallas, simply said it was indefensible. Anderson recalls, I had always said that if I were ever in a position to do something about the situation, I was going to do it, and he did. After he became head of the State Board of Health, he cajoled, argued, and sometimes demanded cooperation from other healthcare stakeholders to get a law passed in Texas that prevented dumping of uncivilized patients because they could not pay for care. As in so many aspects of life, the movement needed voices screaming from the front of the line like Dr. Anderson. Some refer to this legislation on the eve of its passing as a wallet biopsy. Whether wallet biopsy or not, the legislation proves that humanity still has a place in the world and that the value of human life isn't defined by money. Thank you.